You're listening to the Inspired Mom MD's podcast. I'm your host, Dr. Cindy Van Prague. I help physician moms take back control of their time and energy so they can prioritize what matters most and thrive at work and home. In each episode, I bring honest conversations, inspiring stories, and practical strategies, including interviews with incredible women who are redefining success on their own terms. Let's dive in. Hi, everyone. Welcome back to Inspired Mom MDs. Today, I have a special guest. She is someone who brings two worlds together that deeply affect us all, and that is the mind and sleep. Dr. Arjyal is dual board certified in psychiatry and sleep medicine, one of fewer than 10 physicians in North Carolina with that rare combination. She's the CEO and founder of Bliss Sleep and Psychiatry and a former assistant professor of both psychiatry and neurology at Duke University School of Medicine. Originally from Kathmandu, Nepal, Dr. Arjyal has built a career dedicated to treating the whole person, mind, body, and rest. She's passionate about helping people, especially women, understand that mental health and sleep are inseparable. Today, we'll explore the fascinating intersection of sleep and psychiatry and why so many high achieving women struggle to rest, and how physician moms can finally get the restorative sleep that they've been needing and missing. Welcome to the show, Dr. Arjyal.
Thank you so much for having me here, and I'm honored to talk about sleep, especially sleep in women's mental and physical health, how it affects. Thank you.
Yeah. Oh, you're so welcome. And you are an expert, and I've heard you speak before, and I'm really excited that you're here to share
Oh,
your
you're
wisdom.
kind.
So, I would just love to start briefly with your story. What first drew you to psychiatry, and then later to specialize even further in sleep medicine?
So, when I look back, I have always found myself, even as a kid, I was very interested in people's stories. I think I was a good listener. I really like understanding people's journey and their challenges, their success stories. And I think that is something that led me to become a psychiatrist. And I have learned so much in the residency training, and I continue to learn. About human behavior. We can connect with each other when we are very vulnerable. We can connect with each other when we are successful, or anything in between. So that I find very fascinating about psychiatry, and I have really cherished my journey up to where I am today.
So, I get that stories are so powerful. I love hearing
Mhm.
about people's stories. Now, were there stories of sleep deprivation? What drew you to sleep?
Uh, I hadn't planned to be a sleep specialist, very honestly. I had planned to be a psychiatrist and practice as a psychiatrist. And in my fourth year of residency, we have the opportunity to do elective. And I had a wonderful mentor, Dr. Mary O'Malley. She is a psychiatrist and a sleep specialist. And I listened to her talks, her lectures on sleep, and I started thinking, why don't I do a sleep fellowship? Because sleep disorders and psychiatric disorders are practically inseparable. You have to treat one if you really want the patient to feel better overall. I thought it was very fascinating, and also the sleep study reading, I find it fascinating as well. So I wanted to incorporate that in a kind of abstract world of psychiatry, something more objective, so to speak. So I think it was a very good balance that way. Sleep fellowship is 1 year. So I did 1 year of sleep fellowship. So I learned a lot, and that's what I try to do now, incorporate both in my practice. Thank you.
Got it. So it's a balance of the more abstract psychiatry world and the very concrete sleep world
Yeah,
with the studies and the data that you can get from people.
yeah. And when I have the sleep study and I sit down and read to my patients, like this is the slow wave sleep, this is the deep
Mm.
sleep. you do have sleep apnea, you don't have sleep apnea. And even with patients with insomnia, it is very therapeutic for them
Mm,
to take a look at that. For me, in a very selfish way, then I'm not trying to find three or four more people to treat. It's easier for me that I treat both. So I have the results faster there. I mean, the fields that I don't have expertise, I will refer the patients out.
mhm. Yeah.
Yes.
So, for physicians, especially those with kids, or maybe especially those with younger kids, sleep deprivation almost feels baked into the culture. I remember balancing being every fourth night call with having little kids and everything that comes with having kids. And I did not have much time for restorative sleep. And I know this is true for many physicians. From your perspective, what are some of the mental health consequences of chronic poor sleep?
Yeah, there are many. For that, we would have to understand what not sleeping does to our brain, right?
Okay.
So, when we don't sleep or when our sleep is disrupted for various reasons, it could be anxiety, it could be sleep apnea, it could be restless legs, or several other, it could be chronic pain or life circumstances, right? Any kind of acute stress. Our hormones like cortisol, it goes up. Strangely, oxytocin goes up, but can cause mood disturbance.
Mm,
Our good hormones like serotonin, they will go down. Then you're less happy, dopamine goes down. Any kind of sleep disruption is going to exacerbate any mood symptoms. It can be depression. People with depression, either in postpartum, when people have postpartum blues versus depression, right? People are more likely to be diagnosed with postpartum depression if they continue to have disrupted sleep. People with post-traumatic stress disorder are more likely to have exacerbation in their symptoms or be treatment resistant if they continue to have poor sleep. Same with people with bipolar disorder. They are likely to have more phases of mania. I mean, that is one of the main symptoms that we target in people with bipolar disorder is mania. If
mm,
someone has mania, we'd say, okay, all bets are off, have them sleep. We'll take care of the side effects tomorrow. You have to let your patient get your patient to sleep, not just let them sleep. Same is true for people with schizophrenia. So, to answer your question, we as physicians are not immune from any of the stressors or from mental health diagnosis. That is a very important point. So, if we don't sleep well and if we have been diagnosed with chronic insomnia, which is disrupted sleep for 3 months or more, so we are very likely to experience exacerbation of all these symptoms. And if we already have not been diagnosed with mental health problems, we're more likely to be diagnosed versus people who are getting solid sleep for 7, 8 hours sleep. So yeah, those would be the mental health consequences.
wow. So it exacerbates underlying issues that may or may not be diagnosed already.
That is correct.
And
Yes.
it's true for physicians too, not just other people. Yeah,
Yes, yes.
yeah.
We belong to the world
Oh yeah, yeah,
as
we're
well,
all
right?
human, all human.
Yeah.
That's interesting. So patients who struggle with, let's say, anxiety or depression, or you mentioned several others conditions, who also have sleep issues, how do you begin to untangle which came first, or does it matter?
That's a very interesting question. I used to wonder about this as well initially
Okay.
when I started. But now, what I do is, first of all, acute care. And I do really, when I say in my talks that I treat patients as individuals, I do treat them as individuals. Meaning, if a person would come to me and say, hey, I haven't slept properly in 2 months, and I'm going to lose my job if I continue to do this, then for me, that is a priority. Getting her to sleep or him to sleep is a priority.
Mm,
But if the person has depression and has sleep disruption in the context of depression, then I might want to say, okay, let's do it parallelly. I will treat your sleep as well, but let's take a look at your mood symptoms too. So,
okay.
the acuity, and first of all, making sure the patient is safe because not sleeping and chronic insomnia with other factors can actually cause patients to have suicidal thoughts. So keeping
Mhm.
them safe and taking care of the acute issues first and taking care of the bigger picture. So
Mhm.
to answer your question, most of the times now I start things parallelly. So I do a very thorough sleep evaluation and a
Okay.
very thorough
Okay.
psychiatric evaluation because a lot of sleep disorders overlap with the symptoms overlap with psychiatric disorders. I'll give
Mhm.
you a very common example. If someone has obstructive sleep apnea, they can present with low energy, sleep disruption, low interest. It can
Yeah.
be irritable, lethargic, and all of these are also the symptoms of depression. So they are diagnosed as depression and sometimes can be treated for depression for years without having a sleep study. And I ask my
Mhm.
patients, okay, this is all good, but did you ever get a sleep study? And they would go, I don't snore. And then I asked them, does your bed partner, do they snore? Yes. So how do you know you do not snore? Well,
Mhm.
I really don't know, but I think I don't snore, so nobody ordered a sleep study for me. So there is a huge overlap. And in those cases, what I might do is get a sleep study, get them diagnosed, and treat the sleep apnea and slowly see if they actually need the antidepressant.
Yeah.
I try to do it parallelly.
So working in parallel, but definitely addressing the acute issues. How do you help a person with mania sleep?
Yeah, the rule for the insomnia is don't give them medications first.
Hmm.
Cognitive behavioral therapy of insomnia is the uh, gold standard of treatment. For
Okay.
outpatient treatment for chronic insomnia, where I'm getting at is when people have mania, this rule
Mhm.
does not apply. When people are suicidal because of chronic sleep deprivation, then
Yeah.
safety first. In those cases, we use sedating antipsychotics to help them sleep and then slowly taper them off as the patient continues to feel better. Or
Mhm.
even like benzodiazepines are not first line and should not be used on a regular basis. But in acute cases, if patient has severe anxiety, and I'm talking about an inpatient acute setting for a few days, if we are just giving SSRIs, it will be hard for them to just sleep right away. But
Mhm.
they can be tried as well. Some sedating antidepressants can be tried as well.
Yeah. And again, those are probably the exceptions to the general patients population that you see.
Especially
Yeah.
when I'm talking about this, I'm talking about like inpatient facility patients with
Yeah.
mania who we are trying to
Yeah.
contain. If
Right.
they sleep for 2, 3 days, there is such a drastic improvement in the mood symptoms.
Wow. Okay. I'm shifting gears a little bit. Many folks in the world say that they can survive on 4 or 5 hours of sleep a night. And they swear up and down that I've been doing this for years. I'm fine. What do you, as a specialist in psychiatry and sleep medicine, say to this? I'm curious.
That's not sustainable. And
Mhm.
the reason why I say this is we talked about the mental health consequences of insomnia and sleep disruption due to other sleep disorders. Let's talk about the physical consequences. What happens when we don't sleep? Insomnia is not just one symptom, it is connected to a lot of other functions of our body. Let's begin with our sugar level. If we don't sleep, our sugar level goes up because of the cortisol and several
Mhm.
other factors. So, people with diabetes, it worsens. If you don't sleep, your diabetes worsens. Then, same with memory. When we sleep, what happens is we have something called slow wave sleep. There are different stages of sleep, and then something
Mhm.
called REM sleep, dream sleep. So, what these two stages do is they slow wave sleep takes the new memory and takes them from the hippocampus to neocortex, meaning it's like storing the memory. Okay.
Mhm.
And what dream sleep, which is REM sleep, what it does is it clears out the unnecessary memories or unnecessary substances from the brain so that it can clear the brain, make space for new memories. What happens when these two function very well, meaning we get deep sleep and dream sleep consistently, is we can learn new things, we can remember more, we feel better, we have more energy during the day. So, when people consistently sleep less than 7 hours, they have higher risk of having memory disorders like
Mhm.
Alzheimer's, Parkinson's. The risk of dementia is high. And then we have other factors like chronic pain. Sleep is very much related to pain. If people sleep better, there is an internal endorphin that gets released, the cannabinoids that get released that help in pain relief, so to speak. If we don't sleep, we tend to perceive the pain more. So people who don't sleep well have the exacerbation of chronic pain. People who sleep better would have a better quality of life. So, for whatever reasons, if someone says, I don't sleep more than 5 hours, they might have some other consequence, with one exception though. There is less than 3% of people who can survive in less than 6 hours of sleep. They are called short sleepers, but it's a
Mm.
very small percentage. They have some gene mutation that can cause them to sleep less and still feel better the next day. But in regular cases, it doesn't happen. We do need 7 hours or more.
It sounds like sleep is a prescription for all of these things. It's a prescription for diabetes, for chronic pain, for helping to prevent later onset dementia. It's just something that would help a little bit of everything.
It is. I was recently giving a lecture to medical students. We talked about sleep, and I told them sleep is a very healthy way of forgetting that you have had a bad day.
Mm.
You know, if you had a really bad day, if you sleep next day, the problem won't go away, but it won't seem as big as it was the previous day.
Absolutely. That's what my mother used to tell me. Just go
Yeah,
to bed, it'll be better in the morning.
it is
She
true.
was right.
Yeah, she was right.
Are there some small evidence-based changes that you could recommend that would make a big difference for even for the women with unpredictable call schedules and kids? What are some suggestions you would make to help get more sleep?
The biggest evidence-based advice that I can give is if you are not sleepy, please do not stay in the bed.
Okay.
Because psychologically, we're training our mind to say that it's okay not to sleep, conditioning.
Yeah.
So, what we might want to do instead is we want to go to bed when you're very sleepy and have a fixed wake up time. And this is keeping in mind, and with all due respect to the shift workers, it's hard. It's hard. But even within those circumstances, if you could do that, that would be healthy. Reducing caffeine, at least several hours before bedtime would be good, meaning limiting the caffeine only to the morning, reducing any kind of alcohol intake, definitely not smoking. All those things are evidence based and they're very helpful.
Yeah. And sometimes you don't realize, for take caffeine, for example, it can affect different people differently. So even though you haven't had coffee for 8 hours, I mean, what's your take on when you should stop drinking caffeine?
So let's say if you are sleeping at around at like 9, 10 p.m., I would
Mhm.
stop at noon.
Okay, yeah.
But depending on what your bedtime is.
You served on committees that address race, equity, and access to care. How do cultural expectations, especially around productivity and self-sacrifice, play into the way women experience sleep deprivation?
It's a very deep question and an excellent question, but very deep.
Mm,
So when I look at how we are conditioned and how we perceive ourselves, and it plays into sleep with everything else, is also we're conditioned to feel guilty about everything. It's almost like we are in charge of everything and anything goes wrong is our fault, which is not true, but we are made to feel this way. And
mm,
it goes across, I mean, I don't know exactly what kind of percentage in which culture, but I have lived in different countries and it's more or less the same, really. But where it differs is if there is good education, there is an awareness, and if someone divides the childcare responsibility with the partner or household responsibility with the partner, if the partner is aware enough to help in those small steps, personally and professionally. then it becomes easier because you have to carve out the sleep time from the 24 hours. All of us have those 24 hours. If someone takes that off your plate, then you can do something else so that you can sleep. Culturally, if you look at it, worldwide unpaid labor, which is the
Mhm.
household work, childcare, mostly falls on the females. What percentage? It differs again with the society, how evolved it is, how educated people are, and how they implement the education in their practical life. Because that is also very important. And how they are aware that it takes a village to raise a child, and to find that village, the responsibility of creating that village is not on mothers only. I would say it takes a village to create the village too. Because it's not only the mom who's going to find the support for the child, it has to be everybody
Yeah.
contributing to some extent, at least. Biologically,
Right.
understand moms are the ones who are giving birth, and mothers are the ones who are like playing a huge role in lactation, taking care, at least initially. But after that, if you leave that, then anybody can do the childcare part. So I think that is very culturally, it was very interesting to me when I looked at the studies, and also when I have patients with different diverse backgrounds, cultural backgrounds, educational backgrounds. But we have an ability to connect with each other when we are vulnerable, when we have shared problems. And the
Mhm.
solution is also not very different. I tend to say depression is not different in the United States compared to depression in Nepal. The symptoms, clinical signs, symptoms, treatment, it's not
Mm.
very different. Yes, I mean, social support, cultural support, or depending on financial independence, all of them play a role in how the mood symptoms can evolve or can be treated, or access to care. Yes, they are. But clinical signs and symptoms are the same,
Right.
right?
Yeah, because how can you take every culture into consideration with one answer? And I think you did. You tied it back to being human and that the underlying symptoms are there and that the underlying guilt is there too. Thank you for answering that. If you could tell every tired Dr. Mom listening right now, if you could tell her one thing about sleep that could change her life starting tonight, what would that be?
So, first of all, sleep is absolutely important. We cannot survive on 5 hours of sleep. It affects all aspects of our life, including our physical health, mental health, and childcare. And
Mhm.
also, it is important to validate ourselves for the small things that we do. Because if we start validating ourselves, then it will come from external sources as well. But it has to
Mm.
come from us first. And what I would say is, you're not alone. And I'm a physician, I'm a mom, I do understand the struggles. I mean, it's huge, and trying to balance and trying to just not let any of it fall and
Yeah.
shatter. It's a huge burden. But what we can do is, instead of setting up a huge goal, setting up small goals. And once those goals are achieved, then patting yourself, saying, yeah, I did a good job today. For example, if someone is very keen on cleaning the whole house, not setting a goal of like, okay, I'll clean the house, versus, okay, I'm going to clean this table today. That's my goal. So if we set up small goals, we're less likely to disappoint ourselves.
Right.
So that would be my advice for tonight.
For tonight. So tonight, yes, you can take one small step. How do people know when this is just burnout or when they should reach out for help? When should people pick up the phone or reach out and talk to someone just like you for help? How do they know if, you know what, this is a bigger issue? Like, for example, your sleep apnea patient didn't even know that they snored. So, how do you know yourself when to get help or when to just pay more attention to habits like, okay, let's cut back on caffeine, let's get to bed at the same time each night, etc.?
For this, what I would say is, please don't try to do everything yourself, because generally, when your body starts showing symptoms of lethargy, sleepiness, when people around you start telling you, hey, I think you're a little too irritable and this is not you, please keep a low threshold for seeing a doctor. Mental illness and physical illness should be thought about in a similar manner when we are thinking about physicians. If we have something physically, we don't wait for months and try to fix it. Similarly, with mental illness too, it doesn't hurt to go to the doctor. It doesn't hurt to say, hey, I don't think I snore, but I'm so tired and I've done everything. Why don't we get a sleep study? So I would say please keep a low threshold if you have physical symptoms, if you have mood symptoms, if you're just not able to function properly, then it's time to seek help. And I won't wait months because those are the months then you would be suffering.
Oh, that really put it in perspective for me. So if my arm hurt, I wouldn't just chalk it up to, oh, I must be doing something wrong. I would go see somebody. Yes. And
Yeah.
mental health and physical health are one and the same, and they should not be separate.
No.
So, how can listeners find you?
I have a clinic in Cary, North Carolina, but I
Oh,
do video appointments. I'm licensed in North Carolina, Virginia, and Florida. They can email me at contact@blisssp as in Paul.com or call me at 919-342-3627 and I will return your call within 24 hours.
I will put your contact information in the show notes so they can reach out to you.
Thank
And
you.
anyone else can just check out your website, check out more information.
Sure. Thank you.
So I thank you so much for being here today. I really appreciate your perspective and your wisdom and your willingness to be on the show today. Thank you.
Thank you so much. It was a pleasure.
Thank you so much for tuning in today to the Inspired Mom MDs podcast. If this episode resonates with you, please share it with a friend who might benefit too. And I'd be so grateful if you left a review so other women can find me too. You can also connect with me on LinkedIn and explore free resources at inspiredmommds.com. And just a quick reminder, this podcast is for informational and educational purposes only and isn't a substitute for medical advice or care. I'm a board-certified physician, but this content isn't connected to my clinical practice, and no doctor-patient relationship is formed here. Please always talk to your own health professional about any mental or physical health concerns. And as always, take what helps and leave the rest. See inspiredmommds.com for full disclaimer.